Hi, good morning, everyone. We're back again for our next panel discussion, which brings together, as I mentioned, a group of passionate patient advocates, physicians, and also our moderator for this session, Dr. Sarah Rogers, who's the Director of Clinical Affairs at the American Society of Pharmacovigilance. Sarah, across to you.
Yeah, great. Thank you so much, Nigel, and thank you for your focus on pharmacovigilance. As we navigate the challenges in pharmacogenomics, it's important to keep in mind the great potential of pharmacogenetics testing to relay information about how a patient may respond to a medication and use that information to prevent patient harm. That's at the heart of what we do at the American Society of Pharmacovigilance, where we are seeking to address the high rate of adverse drug events in the US. PGX is a tremendous and underutilized tool to prevent medication side effects. Today, I'm joined with 3 change leaders who have identified a serious patient safety issue, and they are taking action in the form of a citizen's petition. This petition is related to fluoropyrimidines, a class of drugs that includes capecitabine and fluorouracil, and is one of the most frequently prescribed group of anti-cancer drugs for the treatment of colorectal, gastric, and breast cancer. There's an enzyme called Dihydropyrimidine Dehydrogenase, DPD, and it is essential in breaking down the drug to eliminate it from the body. DPD deficient patients have an increased risk of serious toxicities, and even one copy of a risk variant would necessitate a lower dosing level. The petition is requesting revisions to the drug label inserts for patient counseling, dosage, and administration, as well as a box warning. We're fortunate today to have Dr. Daniel Hertz, Dr. Gabriel Brooks, and Kenneth Supernon, who will each give us a short presentation on different aspects of the problem. Dr. Hertz is an assistant professor in the Department of Clinical Pharmacy at the University of Michigan College of Pharmacy. His PhD research focused on pharmacogenetic predictors of taxane-induced neuropathy, and his current research is interested in developing tools for individualizing treatment in patients with cancer and translating them into clinical practice. Dr. Brooks is an assistant professor of medicine at the Geisel School of Medicine and the Dartmouth Institute of Health Policy and Clinical Practice. He is a health services researcher and a practicing medical oncologist who specializes in the care of patients with gastrointestinal cancers. Kenneth Supernon is a patient advocate who served over 40 years as a civilian within the US Department of Defense, holding the role of director responsible for operations of logistics information systems. After the loss of his wife in 2012 due to a toxic reaction to 5-FU, Ken has been advocating for pre-treatment identification of patients at risk of severe and life-threatening toxic reactions from fluoropyrimidine chemotherapy. Thank you for joining us. We'll start with a presentation from Dr. Hertz.
Thank you so much, Sarah. Can you see my slides? Great.
Good.
So thank you everybody for coming, and thank you for the introduction, Sarah. So I'm going to be just setting the stage for the other 2 speakers by telling you what is the evidence supporting pretreatment DPYD testing. So I'm going to go back to the background that Sarah just started off with. So there are 2 drugs in the class of fluoropyrimidines, an IV medication called 5-fluorouracil and an oral prodrug called capecitabine. And as Sarah mentioned, they're used in a variety of solid tumors. As with most chemotherapy, they have a range of different severe toxicities that are of concern. So looking at the figure on the right, you can see the pharmacological pathway for 5-fluorouracil. There's one pathway that the drug is metabolized down for efficacy, but we're more interested in this side pathway where actually 80% of the dose of 5-fluorouracil is metabolized by dihydropyrimidine dehydrogenase, which is encoded by the DPYD gene. As Sarah mentioned, there are patients who carry low activity variants or single nucleotide polymorphisms that reduce DPD activity. So I have here the 5 validated variants that we're most interested in, and I've highlighted in red some of the most common names, although there's a lot of different aliases that these different variants go by. You can see all the way on the right-hand side that each individual variant has relatively low allele frequency, but the combined carrier frequency in patients is about 5 to 6%, meaning that about 1 in 300 patients is homozygous and can have complete DPD deficiency. There are, of course, many other rare or singleton diminished activity variants that have been reported, but these 5 have been validated. So just to show you a little bit about the consequences of these variants, on the left-hand side, you can see an ex vivo screen of metabolic activity comparing non-carrier DPD versus the DPD enzyme that carries one of the low activity variants. And you can see much lower DPD activity in these variant carriers. On the right-hand side, you can see the systemic consequences of this. So in the diamonds is a single patient who is a STAR2A carrier who is given a standard dose of 5-fluorouracil, and you can see much higher systemic concentrations of 5-FU for a much longer period of time relative to 6 control patients that had normal or wild-type DPD or DPYD genotype. There have been several different studies looking at the retrospective risk of toxicity, but I highlight this one because it was one of the largest and best done studies, and it was done in a prospective clinical trial run by the NCCTG. So about 3,000 patients with stage 3 colon cancer who were receiving standard 5-fluorouracil containing combination chemotherapy. These patients were genotyped for 2 of our known decreased activity alleles, STAR2A and PD949V, and the primary outcome here was grade 3 or higher, so severe 5-FU related adverse events. You can see on the bottom left, the rates of toxicity in our STAR2A carriers was about 90% versus 33% in the wild type patients. And similarly with the D949V carriers, a rate of about 80% toxicity versus that same 30% in the non-carriers. So you can see odds ratios in the realm of 10 to 15, odds ratios in the realm of 10 to 15 and significant p-values. And this was consistent across all major subgroups. As I mentioned, there are many studies that have looked at this. So here was a meta-analysis looking at 4 of the validated variants. And in each case, you can see in the table on the bottom, adjusted relative risks in the range of a 60% to a 4-fold increase in toxicity risk for carriers of each of these variants relative to wild type patients with, again, highly significant p-values. So these are all highly validated variants, and we know that patients who carry these variants are at increased risk. We also know that patients who carry these variants are at increased risk for treatment-related deaths. So there have been many case reports in the literature of patients who passed away from lethal toxicity and were later found out to be carriers of DPYD variants. Dr. Brooks actually has some data where he did an analysis and has reported that the risk of toxicity-related death in DPYD variant carriers is somewhere around 3%, although given the small numbers of events, it's hard to get precise estimates at this point. Unlike a lot of our other pharmacogenetic associations, there's actually been some prospective trials. So here we have, I would consider probably the best trial that's been done. This was a prospective study of patients who were scheduled to receive fluoropyrimidine, greater than 1,500 patients in this study. All patients were underwent pre-treatment genotyping for DPYD STAR2A, following this dosing regimen that's listed here. So in non-carriers, they received a standard dose. In carriers of a single copy, they had a 50% dose reduction. And in carriers of 2 copies, they had an 85% dose reduction, followed by dose escalation as tolerated. And this is pretty consistent with the CPIC guidelines for dosing fluoropyrimidines in DPYD carriers. Then they made several important comparisons. So the first comparison was a comparison of their STAR2A carriers who received adjusted dosing on the study with a historical control group of STAR2A carriers who had received standard dosing. Another comparison of interest was their STAR2A carriers who received adjusted dosing versus their wild type patients who had received standard dosing on their trial. And this they looked at to see what are the possible risks of dose adjustment. They also did an analysis of healthcare costs. So in getting to their results in their primary analysis, as expected, STAR2A carriers who received a dose reduction had a significant reduction in severe toxicity from about 70% to 30% from the dose adjustment. That's relative to the historical control patients. There was also a nominal reduction in toxicity-related deaths from about 10% in those STAR2A carriers who had received full dose to 0% in their dose-adjusted STAR2A carriers. In their comparison of the STAR2A carriers who had received dose adjustment versus the wild type patients receiving standard dosing, you can see a normalization of grade 3 toxicity and a normalization of drug concentrations, strongly suggesting there should also be a normalization of efficacy, though that analysis wasn't conducted in this study. Finally, in their economic analysis, they showed that DPYD screening actually saves money per patient. Here they estimated about $60. So just to summarize what we know about the benefits and harms of pretreatment DPYD testing, starting with the benefits of dose reduction. So in our DPYD carriers, which is again about 6% of patients, there is a reduction in grade 3 toxicity from somewhere on the order of 50 to maybe even up to 80 or 90% down to about 30%, and a reduction in death from an estimate about 3% to, we believe, much less than 1%. We also believe that there's a greater decrease in homozygous patients, although precise estimates are unavailable due to the low frequency of these patients in the studies that we have analyzed. We also have to think about what are the potential harms of testing and dose reduction. The first potential harm that we hear about a lot is the potential for decreased efficacy, particularly in those 30% of DPYD carriers who were unnecessarily adjusted because they wouldn't have experienced toxicity. We believe there's a low concern for diminished efficacy for the following reasons. First, as I mentioned, there's a normalization of drug concentrations and toxicity when you dose reduce the carriers relative to wild type patients, again suggesting a normalization of efficacy, which has been shown in some small studies. Secondly, the dosing recommendations recommend an escalation to tolerability after cycle 1. So again, all patients should be receiving their maximum tolerated dosing and maximum efficacious treatment. Another potential harm that we sometimes hear about is this sort of false sense of security in the 30% of non-carriers who receive full dosing. We believe there's low concern for harm because these patients do not have any change in their dosing or monitoring relative to standard of care. Whether or not you test these patients, they'll receive standard dosing and they'll have the unfortunate toxicity that they would have had whether or not they were tested. Finally, there's some concern about genotyping costs, particularly due to the low frequency of the DPYD carriers. In the analyses that have been done, preemptive DPYD testing at best saves money and at worst is cost neutral. This is because there's very high treatment costs in the carriers who receive full dosing due to their high risk of hospitalization, and also the high cost of an antidote to fluoropyrimidine toxicity called uridine triacetate, which actually was somewhat recently approved and isn't included in a lot of these cost analyses. So I'll just finish by talking about the evidence supporting pretreatment testing. So in general, we've decided as a community that the evidence required to do pretreatment genetic testing should be clinical utility, which we define as the use of genetics to guide patient care and improves treatment outcomes. I think that I've showed you the evidence from prospective studies, but there are really two different ways to demonstrate clinical utility based on an Institute of Medicine report. The first is a retrospective analysis of a prospective study of the archived specimens, and I showed you that in the NCCTG study. And the second are prospective clinical trials where the test directs patient management, and I showed you that in the prospective genotyping study. So I believe that we have met this threshold using both of the possible paradigms, and I think the time is right for pretreatment testing in all patients. Thank you very much.
So I believe that I am next up here. My name is Gabe Brooks, and I'm a medical oncologist here at Dartmouth-Hitchcock in New Hampshire, and an assistant professor at the Dartmouth Institute for Health Policy and Clinical Practice. I'm going to talk about screening for DPD deficiency, specifically implementation in our practice here at Dartmouth, and within the context of the practices in the United States. So the first question, which Dan has addressed already, is why to screen for DPYD gene mutations or DPD deficiency. And I'm going to use both terms. DPD deficiency refers to the general syndrome of inability to metabolize standard doses of the 5-FU, whereas DPYD genotyping specifically looks at the genetic level changes that cause that syndrome. So the reason for screening is to prevent avoidable deaths and also toxicities. And I have the picture of the airplane here because, we believe that the acceptable number of airplane crashes is very, very close to zero. And yet in chemotherapy, the acceptance of toxic and treatment-related deaths has been higher than that. And so, I want to make a case that unexpected or unpreventable toxic effects are part of treatment with chemotherapy. There are patients where we don't know that they're going to have an adverse reaction, and we don't know how to prevent that adverse reaction. However, when an adverse reaction is predictable or preventable, we should have a similarly extremely low threshold for tolerating those adverse events if we can predict and prevent those. With regard to which test we should be using, Dan discussed DPYD genotyping, which is the test that I'm going to spend most of my time talking about, and which is the test that right now is most available and easiest to interpret it for detecting patients with DPD deficiency. Other tests, though, include whole gene sequencing of the DPYD gene, which can identify rare variants which may impair gene function. But sometimes we don't know with certainty what the impact of these rare variants may be. There's another test, which is the measurement of the plasma uracil. And this is done in some parts of Europe, in France and other countries where the European Medicines Agency has recommended universal DPD deficiency screening. And that test is strong in that it can detect DPD deficiency even in patients who don't have one of the typical variants in the DPYD gene. And then there's also this multi-parametric testing, which is advocated by some in France and other countries, and incorporates both the DPYD genotype, the plasma uracil, and other patient factors in trying to determine a patient risk. So DPYD genotyping, I mentioned, is the test most available in the United States, so most ready for implementation here. It can be done in-house with existing DNA sequencing technologies and equipment. It has a billable CPT code, so it can be billed to an insurance company, including to Medicare. There is a listed reimbursement amount in the Medicare Clinical Laboratory Fee Schedule for this CPT code, which is only $174, relatively modest compared to the cost of a lot of the things that we do. That doesn't mean that it's universally covered by insurance and even by Medicare. Medicare doesn't have a national coverage determination for DPYD genotyping, so it's covered in some areas by Medicare and not in others. We've found here in our practice that we don't get denials from most of our commercial insurers. We have a few patients where we've gotten denials from commercial insurers, but most of them are able to have the testing through commercial insurance. Although for our Medicare patients, we've recently had to start having them sign an advanced beneficiary notification letter that it may not be paid for under Medicare. So there are issues with reimbursement for testing. We know that the DPYD genotyping may be less sensitive than phenotypic tests like the plasma uracil. And one of the biggest issues is that there may be limited sensitivity in non-European, non-white patients because most of the information about the genotypes that contribute to DPD deficiency comes from these well-studied white populations, and we don't have as much information about the kinds of genotypes that may confer risk in non-white patients. So regarding the effectiveness of DPYD genotyping that Dan has already covered, we think that the number of patients needed to screen to prevent one death is on the order of 500 to, on the high end, 1,000 patients. So if we can screen 500 to 1,000 patients, we can prevent one death. In our practice at my center, where we treat between 100 and 2 patients a year with these drugs, that means that it would take maybe 6-7 years in order for us to prevent one death. And frankly, we think that's worth it. But even if we're not preventing deaths each year that we do this, we're preventing hospitalizations each year. I mean, some of those hospitalizations are very costly and really very traumatic to people who are hospitalized. So we implemented this in fall of 2016. Rather, I started doing this routinely at that time after some experience with patients, one patient in fellowship who died after a toxicity from 5-FU. And seeing other patients with severe toxicity and meeting Ken. So we learned, I learned about this issue. I convinced my colleagues here that we would adopt it as a group among our GI oncology provider team. And we've seen increasing use by other providers at my center. In the fall of 2020, we moved our test, our genotyping test in-house here at Dartmouth. And we have a 4-day turnaround time now on the test, which has made it really very easy to incorporate with our workflows. We've screened over 150 patients as a center. We've identified 8 patients at least with DPYD gene variants, and 7 of those patients have gone on to receive dose-reduced treatment with fluoropyrimidine chemotherapies, and I'll have an example of one of them in a moment. A couple of the pain points that we run into in clinical practice is the reimbursement and cost issue. How do we proceed if testing's not covered? And I mentioned that we're having to have our Medicare patients here sign an advanced beneficiary notification notice, which introduces friction into the process. Although we find that most patients, when we tell them our goal in doing this is to make sure that you don't have a severe toxic reaction, they're willing to do that. They prefer that to taking the chance. There's a question of urgency. What do we do if there's no time to wait for a lab test that may take 4 weeks, or at worst, if you have to send it out, could take 7 or 8 days to come back? I'm sorry, 4 days or up to 7 or 8 days. What do we do if we can't wait that 4 days to 1 week? Well, in those cases, which are relatively infrequent in the clinical situations that we use these drugs, we can have a discussion with the patient and decide, is the risk of waiting outweighed by the benefit of getting a result on this test, or is it the other way around? So we need to have a little discussion, and that adds to, the time spent with the patient, but I believe that's worthwhile. What if the physician forgets to order the test? Well, that's where building this testing into our workflows is really important, so that we don't forget, so that we get the test as soon as we identify a patient as a treatment candidate. And even better if the patient had testing at birth and we already knew they had a DPYD gene variant. What if a patient has a toxicity despite a negative test? And as Dan was alluding to previously, DPYD genotyping is not a perfect test for DPD deficiency or for other mechanisms of 5-FU toxicity. So if patients have toxicity, we just have to learn that we have to make adjustments as we would even if we hadn't gotten a test result. So it doesn't exclude toxicity, and it doesn't mean that we can avoid managing those toxicities. Briefly, our workflow is that we identify a patient who is to receive 5-FU or capecitabine. I, as the provider, enter the order for the genotyping on the same day that I identify the patient's going to receive that treatment. The patient goes, again, the same day to have the blood drawn at our clinic. And so that way we minimize the turnaround time on the test result. And then we schedule their first chemotherapy treatment with adequate time. And so now I know the days, my lab reports this result on Thursday mornings and on Monday mornings, so I can schedule patients with that in mind, knowing when the result is going to come back. And our whole team knows what we're doing and why we're doing it. And so everybody knows where to look for this result and to make sure that patients have a DPYD genotype result before starting treatment. I said I'd mention this patient briefly. This is again a stock photo, but a real patient. She had metastatic colon cancer. Her DPYD genotyping showed a star 13 mutation, which is one of the complete loss of function alleles. She was started on standard FOLFOX chemotherapy, but with a 50% dose reduction, as advised in the CPIC dose adjustment guidelines for this genotype. Despite the dose reduction, she actually went on to develop grade 4 neutropenia with an ANC as low as 130, but still her counts recovered by day 21, and she was able to continue treatment with only a 1-week delay, and she did also have a further reduction of her 5-FU dose. Now, I can only imagine what would have happened had we given her full dose in the first cycle rather than starting with a 50% dose reduction. And most other patients, I'll say that the 50% dose reduction is adequate to prevent a severe toxicity event. But I worry that this is a patient who may have died if she had gotten the full dose chemotherapy. I'll leave you with this, implementation readiness for DPYD genotyping in the clinic. Anyone in the United States can do this. You need to educate your clinical team about the purposes of DPYD genotyping, identify which lab is going to do your testing, how you're going to order the test, and establish clear workflows, and then educate your team about interpretation of results. And here we rely on the CPIC guidelines, which really do an excellent job of letting you know how to treat these patients. So I'll stop there. Thanks for the chance to talk.
thank you for the opportunity to be here with you today. And as Sarah indicated, I started learning about this subject back in 2012. And what I hope to do today is to walk you through some of my personal experience in learning about this. And at the end of this, I hope you take at least 3 items away from this. The first of which is that all too often we learn too late that a person has DPD deficiency. Secondly, that this is not such a rare condition that we should just simply sweep under the rug and ignore. And last, as you've seen in the presentations here, is that there's increasing medical evidence that there is value in pre-screening without compromising efficacy of the drug treatment and by increasing the safety of the use of the drugs. When my first wife, Kath, learned that she had cancer, we went to 3 different cancer centers to learn what our treatment options would be. In each instance, it was that we would expect chemotherapy, radiation, and surgery, the order of which did not matter. And we were told that the chemo would be fairly well tolerated. She would not even have to worry about losing her hair. She started with chemo, and it turns out she had bigger worries than simply losing her hair. For in the first week, she became increasingly weak and resulted on the 9th day of her collapsing, at which point I had her taken to the emergency room. She spent 2 weeks in the hospital, the last 3 days of which were in ICU, and she passed away. The first indication that I had of DPD deficiency was in the emergency room. You see 2 images here of her, the first of which is 3 weeks prior to the start of treatment. And here's how she appeared on the right-hand side when she was admitted to the emergency room. Since that time, too many people have shared with me that they too learn of this condition too late, and they have been willing to share their stories, which you can find at the website below. Well, after this experience, I decided I wanted to learn more about this to try to find out why we have the standard of care that we have today, and to be able to share with people this experience so that they might avoid this sort of problem. And I was dismayed to find that the governing organizations responsible for setting treatment guidelines and for safe product use dismiss this as simply a rare condition. Well, if we're going to do that, we don't recognize that we have a problem, then there isn't any hope of improving the standard of care. And yet, when I continued to read articles, it puzzled me how we could dismiss this as a rare condition when, as you've heard already, that anywhere between 3 to 8% of the Caucasian population is genetically predisposed to risk, and that anywhere between 10 to 40% of patients receiving this form of chemotherapy suffer a grade 3 or greater toxic reaction. Well, thankfully, I did get support as I was trying to learn more about this, and I discovered that Dr. Ciccolini in Marseille, France, was successfully pre-screening patients without compromising their treatment outcomes. And secondly, somebody had indicated to me that it's possible to petition the FDA. So that's what I did in 2014. I learned that there's a citizens petition process, and I asked the FDA to acknowledge properly the risk involved with the use of these drugs and to take the next step, which is to recommend preventative measures such as pre-screening and dose management of the drugs. Well, to the FDA's credit, in 2016, they acknowledged the risk. They said it's no longer rare and adverse outcomes no longer unexpected for patients with DPD deficiency. And they even added fatalities to the list of possible outcomes. However, the FDA fell short, in my opinion, in terms of taking the next step. That is, they did not recommend pre-screening or dose management. Instead, what they have in place are these two measures. The first of which is to rely upon patients to self-report to the physician that they have DPD deficiency. Remember what I said just a moment ago. Most people are unaware of this condition. Secondly, they rely upon an antidote, which is treating after an adverse event. Well, thankfully, research continues. There's more evidence growing that pre-screening and dose management can be successful in promoting safety and treatment efficacy. And authorities in Europe are paying attention. The French first required phenotyping in 2019, and then the EMA followed suit in a fashion in 2020. They allow for either genotyping or phenotyping, and they don't require, but they recommend it. I still think that this is a step forward, and the fact that they recognize, or that they allow for either testing, I think recognizes that the testing that we have in place today is not perfect. However, testing is better than not testing. And secondly, as the demand, the use of testing grows, then testing capabilities will improve over time. The market will respond to that. So I am fortunate now to be joined with the likes of Dr. Hertz, Dr. Brooks, and others who agree that DPD deficiency today, without pre-screening, is identified too late. Secondly, it's not a rare condition that we can simply ignore. And lastly, that medical evidence shows that there is indeed value in screening patients before the start of treatment and in dose management. We have joined together and we have asked the FDA to again consider revising its drug labels and to adopt the standard of care that we now see in place in Europe. You may read this petition, and I hope you do so, and I hope you join us in this effort. Thank you so much.
Thank you, Ken, for sharing your story and advocating for change to protect others. At ASP, it occurred to us there was no official day to raise awareness about adverse drug events, so we requested one, and that request was granted. The inaugural National Adverse Drug Event Awareness Day will be this month on March 24th. And on this day, we're launching a campaign to encourage patients to share their ADE journey and asking healthcare professionals and organizations to talk about how they champion medication safety. And if you work in pharmacogenomics, you may not realize it, but you also work in pharmacovigilance because you are preventing adverse drug events, and your work could serve as a model for others in the fight against the fourth leading cause of death in the US. Patient voices need to be heard, and we need to work together to develop solutions. So please mark your calendar for the first ever National Adverse Drug Event Awareness Day on March 24th. And you can participate simply by sharing your story and using the hashtag #4thCause. So today we're talking about adverse events caused by chemotherapy, which is toxic by design. It's meant to damage cancer cells, and as an unwanted byproduct, also damages non-cancer cells. Most people are aware of the serious side effects traditional chemotherapies can cause. What people may not realize is that there are genetic associations that predispose certain patients to having more severe reactions. In some cases, we can identify that predisposition with a simple cheek swab. We recently held a community dialogue with a participant group, and over 6 weeks, they learned about pharmacogenetics testing, and we learned about their values and priorities related to pharmacogenomics as they were becoming more knowledgeable about the topic. It was a diverse participant group, and they differed in opinion on a lot of the questions we asked. One thing that all the participants agreed about was that they should be informed that this type of testing exists and it can prevent issues with their medications. They voiced concern that their physicians may not be knowledgeable about it. They knew that it may not be covered by their insurance, but all the participants felt adamant that they should be told about the testing. So Ken, your loved one gets a cancer diagnosis. You then have to decide together how to approach treatment. Based on having gone through this experience, what is the best way to ensure patients are notified of the option to receive DPD testing rather?
Well, I think that, I can tell you what's not the best way. And that is to expect the patients to come to the table with that knowledge. As I indicated, that most people identify this after the fact. They are unaware of this. And the experience that I have in dealing with other families is that even though I have the website that's listed on the cover page, it's been out there. People come to it after the fact, and I don't understand how to get that earlier so that they recognize that there's an issue. Now, I suppose one could say that there are patient organizations that deal with colon cancer, and they indicate that here's a risk that we have here that you should inquire about. They do indicate that that if you have DPD deficiency, then you should reveal that to the doctor and perhaps look at your dose adjustment. But I think that the best way for patients to be aware of this is for, as Dr. Brooks indicated, is to have the physician have the discussion with the patient, indicating what the risk may be, and offering to them taking this test. And I think that it has to start there, because the patient and their family are going to be so focused on, I have cancer, and what's the best way to treat this? And they are trusting that what options are being provided to them are going to be safe, not just effective, but that they're going to be safe. And so there's a leap of faith there. And I think that it has to fall upon the physician to have that dialogue with the patient.
And Dr. Hertz, what's your perception of the major barriers to physicians ordering pre-treatment testing?
Yeah, so I completely agree with Ken. This is the physician's responsibility and should be. And Dr. Brooks talked a little bit about some of the logistical challenges, which I think at a system level can all be resolved with good planning. We did some survey work asking physicians why they don't test, because most of them do not. And by far, the most highly endorsed response was that because the guidelines don't tell them to. So because the FDA hasn't told them to, because the NCCN, because ASCO hasn't told them to, they're not going to. And they're waiting for someone to tell them that this is recommended or required. As soon as that happens, they'll all begin testing. When we asked them about the logistics, they didn't really have major challenges there. We asked them about the evidence. They didn't really have major concerns there. There was some concern, as I mentioned, about decreased efficacy, but they all agreed that this decreases toxicity. They agreed this is worth the cost. They're just waiting for the guidelines to get on board and tell them that this is what is best practice now, as they have in Europe.
Great. And Dr. Brooks, from your perspective as a physician that does order pre-treatment testing, what do you think is needed for others to follow suit?
I think that it's awareness, and I think that the guidelines, I think the two pieces of wider awareness and more evidence, more recognition of the guidelines. I think, one thing that, as humans, we're attuned to things, high threats that are relatively common, risks that are relatively common. I think there's good evidence that, our perception of risks breaks down when the risks seem more rare. Very few people will accept, if you say there's a 1 in 500 chance that you could die from this treatment, and we have a test that could prevent you from dying, if that was a lottery, if you flip that around and said you have a 1 in 500 chance of winning the lottery, I think you'd have a lot of people buying those lottery tickets. So I think that there's just a lack of sort of understanding the risk that this poses, the degree to which it can be mitigated, and the fact that we have the tools that we need and we can prevent these deaths. Even if we're preventing at my center 1 death every 5 years, well, geez, that's 1 less person like Ken who's lost a spouse, and that matters, especially when we can show that it's cost effective, and the numbers show us that.
And Dr. Hertz, it seems like you have engaged with the groups that write the treatment guidelines. How receptive do you think oncology guideline developers would be to incorporating DPD testing into the treatment algorithms?
Yeah, so we have found that they are not very receptive at all, and we're not really sure why. So we submitted a request to the NCCN. Actually, Ken did this several years ago. I did this last year, providing all the evidence, providing everything that we just explained to you and the audience today, showing that this is effective and cost effective and improves outcomes. And there was no appetite for adding this to the colorectal guidelines. We're not really sure why. We submitted a similar request to ASCO to add a comment or add an evidence review to their guidelines, and that was also not granted. Interestingly, the NCCN guidelines are really reflections of current practice. So when we ask the NCCN guidelines to add this, they say it's not currently being done in practice, so we're not going to add it to our guidelines. And then we say, why aren't you doing this in practice? They say because it's not in the guidelines. So we have a sort of chicken and egg situation, and we're not really sure how to break that cycle and get someone to make the first move. But we think that the evidence certainly supports adding this to guidelines.
And Ken, you've been successful in initiating an update to the drug label once before. How has your experience been in engaging with FDA?
Well, there are a few parts to that. The first of which is that I'm thankful that they have a citizens petition process where they are willing to allow somebody like me, or anybody for that matter, to put forth propositions that they ought to consider. As you indicated, back in 2016, they did respond. After deliberate consideration, it took 2 years for them to do that, but there was positive recognition that there's risk. I have to say, and so I give them credit for responding to that, but I think that it's interesting here that it is a bit of a black box, is how I will put it, in that I don't know what the process is, and they are unwilling to share what that process is. And so we put forth the petition at this point in time, and they are unwilling to comment on it until they make their final determination. So it's sit and wait. And in the meantime, people are, I would encourage people to go and weigh in on the merits of the petition, and they can read that there. They can read all the references that we included, which are substantial, but they can't read the reference. They can read the citations, but they can't read the references. And then they can also see the other people that have joined with us in doing this petition. The thing that I'm a little concerned with is why the FDA rejected pre-screening before is much like what Dr. Hertz indicated, the chicken and the egg. They said, well, the NCCN guidelines don't call for it. Therefore, we don't think that it's appropriate. I'm hoping that what they see is that what the progress is being made in the drug labeling in Europe, and that they will do the same, and that the NCCN will follow suit.
And Dr. Hertz, we heard a bit about test ordering workflow from Dr. Brooks at his clinic. What does that process look like at your institution?
Yeah, so at our institution, I've been working mostly with the breast oncology team, and they have looked over the evidence, and they are now believers in testing. So we have added DPYD genotyping as a test that's orderable in our electronic health record. It gets automatically sent to the Mayo Clinic, where a lot of our testing goes. And we found the turnaround time to be about 5 days. So we haven't had very many logistical challenges. I think it sort of changes tumor type to tumor type. But I think once you get the physician champions and you convince them of the evidence, then it can move pretty quickly at an individual institution.
Right. And as I think you all alluded to, there's a cost associated with ordering and interpreting the test results. Dr. Brooks, what is your argument to the people who are looking at the problem from a purely financial perspective?
So my argument is that that we have evidence. First of all, that medicine, our goal in medicine is to help people feel better and live longer. all of our interventions have some cost, or nearly all of our interventions have some cost. I mean, we have evidence that this is, in some situations, is cost saving. My team presented an abstract at the recent ASCO GI Summit that this is, in the US setting, where we have slightly lower prevalence of some of these variants, it may not be cost saving, but it is certainly cost effective. And so if you know, we, as an oncologist, I routinely use drugs that are not cost effective. Many of the drugs that we use in standard care flunk any traditional cost effectiveness test. And yet here we have something that is cost effective. So if people want, if you're a physician and you want to do something that is cost effective and so gets good value for money to help your patients live longer and feel better, then you should do this before you adopt other things that are more costly and less efficacious. So I think there's a very strong argument to be made in favor on that basis.
And Ken, how much focus do you think the cost of testing should be given?
Well, cost is always a consideration. I understand that. But I think in this case here, clearly what people are going to want to see will be safety. They want to see the safe use of the drug, and they want to have a positive outcome. And as we've already heard, is that it's relatively low cost for something like this. And I like Dr. Brooks' analogy. Okay, you know what? So let's play these odds. Even if I have to pay $174 out of pocket, if I've got a chance that it will help me avoid a severe toxic reaction anywhere between 10 to 40% of the time, I'm going to spend that $174 because I want to have a safe and effective treatment.
Well, Mr. Supernet, Dr. Hertz, Dr. Brooks, thank you for illuminating the issue for us today. I think everyone can agree this is a commendable effort in bringing a serious but solvable problem to the forefront. I will turn it back over to Nigel for any questions or comments from the audience.
We have had some great questions come in from the audience. So the first one being, how do you suggest the cancer guidelines be updated with this recommendation, and are you approaching the guideline committees?
So I think Dan mentioned already, you know, that that we have been part of various efforts to approach NCCN, which is the National Comprehensive Cancer Network, which is one of the most powerful, most widely looked to guideline bodies in the United States, and also ASCO, which is my specialty society of the American Society of Clinical Oncology. You know, we've encountered resistance from those guideline writing agencies, and as Dan has said, you know, we feel like the evidence is rather plain, and yet not everybody agrees with us. And some of this is because this is a drug that's been around since the 1950s, and people feel like, well, if we've been using 5-FU since 1950, we probably ought to have it figured out by now. And yet other evidence has changed. You know, our understanding about genes and enzymes and how this drug is metabolized has certainly advanced since 1950. And now we have the data that Dan presented from those 2 prospective clinical trials in the Netherlands. So we really have this great data, and yet for some reason there's a lack of engagement. And I wonder if some of that is just people who have grown up doing something a certain way and are resistant to change. And so we're trying to wear that down with more and more evidence and more data and patient stories like Ken's story and the story that you'll see on his website, you know, stories of other people who have been through this. This happens probably hundreds of times per year in the United States. So to imagine that there are hundreds of people like this who lose a loved one is really heartbreaking. And I think all we can do is keep talking about it.
I would just quickly jump in and say it's not necessarily a broad resistance to change, because when they find a new genetic factor in the tumor that maybe 1 in 1,000 tumors carries, and that might tell you that you should use some targeted agent, people start testing for that easily. You know, I think this has to do with it being a toxicity issue and not an efficacy issue. People love to use new drugs that are more effective and new treatments that might have some benefit, even if they're really expensive and even if testing is expensive and the genetic anomaly is really rare. this just has to do with some acceptance of toxicity in chemotherapy, and the feeling that, you know, we need to do whatever we can. Patients will put up with it. I think that this is because it's a toxicity issue, and there's just not enough respect for the patients and the safety of patients, and the fact that this could improve that situation.
Well, I would agree that I'm not going to paint a broad brush, okay, for this, but there should be two sides of the same coin that should be considered. The one is the effectiveness of the drug, and what do we target for that to be able to treat the tumor properly. And secondly, we ought to assess the person's ability to be able to tolerate the treatment. And for some reason or another, the guideline committee hasn't adopted that yet. They at least put in that there are, in the footnotes, that there is evidence that there may be some value in doing this, but they haven't taken the next step. So maybe they've got their toe in the water, but that's not sufficient. There isn't any reason why they shouldn't, in my opinion, why they shouldn't recommend a change in the guidelines at this point.
Excellent. Well, thank you all very much for those comments. Are there any other metabolic factors outside of DPD that play a role in toxicity?
There are other reported metabolic factors. There are other things besides just DPD genotypes. So there's some epigenetic factors. There are some other genes involved, but I think that their contribution is relatively minor compared to that of DPD and DPYD. I think that if we got to the point where DPD genotyping or phenotype testing was standard of care, then we, as Ken said, we would start adding to and improving that testing by adding other genes, adding epigenetics, adding other clinical variables. But we could take this one relatively simple genotyping, look for these 5 variants. That one step would cover 70 to 80% of this issue, in my opinion.
Great, thank you, Dr. Hertz. We've probably got time for one more question here. How does pre-screening for cancer and other diseases become the norm rather than the exception? And how would the cost be managed by payers?
I think Dan may have some things to say about this, but the idea that Dr. McLeod raised at the beginning of the conference, that these are things that don't change over time. So somebody's germline DNA is a constant. So if we need systems, in my health system, when I identify someone who has a DPYD genotype abnormality, we don't actually have we have an allergy system, but we don't have a genotype system implemented. There should be a way that someone is at birth has their pharmacogenomically relevant drugs, that their electronic health system recognizes any abnormalities and flags a drug that may be contraindicated. Dan, I don't know if you have more to add to that, but that's something that's to me is the next step.
Yeah, I know we're running low on time. I would just say that especially in cancer, where we do so much genetic testing, we do tumor genetic testing, we do patient genetic testing for hereditary cancer syndromes, we look for BRCA, we look for all these different things. If we just added DPYD to as many panels as we could, we would have this information on a much, much, much higher number of patients than we currently do. And we could save a lot of patients, a lot of suffering and a lot of deaths by adding DPYD to the genetic testing that's already being done in patients with cancer.